For this lecture, we're going to talk about Chapter 47, assessment of the kidney and urinary function. Here are your learning objectives for the end of this chapter. Okay, so we're going to start with a brief overview of the anatomy and physiology of the urinary system. So if you look here at the picture, you have a breakdown of the organs of this system. So we start with the kidneys. Those are at the top. The kidneys help to filter blood, get rid of waste, and produce urine. So we'll go more in depth on them throughout the lectures, but just be aware that is where they are placed in the abdominal cavity. And if you remember back to our endocrine lecture, you have your adrenal glands, those little triangle glands that sit up the top. Then our next area where that urine would flow from the kidneys would be the ureters. These are those tubes that help to transport urine from the kidneys to the bladder. Then next is the bladder. That's that kind of circular shaped organ there down in the lower pelvic area. This helps store the urine until elimination, and your bladder does extend and increase in size and decrease in size depending on how much urine is stored in that area. Then we have our urethra. This is the opening to the outside of the body. This is that portal or the tube that extends from the bladder to the urethral opening, and that is where the urine is excreted outside of the body. Keep in mind that for males, the urethra is longer. That's why when we're cathing somebody or putting in a Foley catheter, we go all the way to the bifurcation. For females, it is a little shorter, so that comes into play for some of the disorders that we'll talk about throughout the next couple chapters. Then we have our nephron. So our nephron we're going to discuss is the functional unit that's responsible for filtration. It's responsible for reabsorption and secretion. So it helps with fluid and electrolyte balance and helps with secretion of those waste products in the urinary system as well. Okay, so first we're going to start talking about the nephron. So the nephron is the most basic functional unit of the kidney. Each kidney contains about 1 million nephrons, and its main job is to filter the blood, regulate the fluid electrolyte balance, and reabsorb water, and it helps with removing waste and forming the urine. So each nephron has two main parts. There is the renal tubular and the renal corpuscle. So the renal corpuscle contains that glomerulus. This is that capillary network and contains the Bowman's capsule. And we'll talk a little bit more about that later in this lecture. Our renal tubules are long twisting tubes that helps to modify the amount of filtrate that's in the urine through reabsorption and secretion. So in our renal tubule, you can see it's made up of the proximal convoluted tubule, the loop of Henle, which has the descending and ascending limbs, the distal convoluted tubule, and the collecting ducts. When we look at the process of filtration, which occurs in the glomerulus, we look at how blood enters into that glomerulus under pressure, and then it acts as kind of a sieve that helps to allow water, electrolytes, glucose, amino acids, and waste products to pass into that Bowman's capsule. It helps to prevent proteins and blood cells from entering into Bowman's capsules and keeps it in the blood. So that kind of helps with filtration. When we look at filtration, what we measure and we're going to need to know is the GFR, or the glomerular filtration rate. Normally this is 125 mLs per minute, and a decrease in that GFR can be from either a lack of blood pressure due to hypotension or dehydration. We also will see a decrease in urine output from a decrease in that GFR and an increase in our BUN and creatinine based on that filtration rate. Other things that occur in that nephron is the reabsorption. So this occurs in the tubules. This is where our body holds on to essential substances that the body needs to function. This mostly occurs in the proximal convoluted tubule, but it does continue throughout the nephron. Now, substances or essential nutrients that the body does keep and reabsorbs is usually water, sodium, glucose, amino acids, um, sodium chloride, and then calcium and bicarb. So this is kind of how our kidneys work to maintain water, help with hydration status, and disorders that we've seen in the past, like diabetes insipidus. So if you remember, ADH causes the kidneys to retain water and can lead to a concentrated urine. And no ADH, like in diabetes insipidus, leads to a dilute urine. Our nephrons also help with secretion in those tubules, so this helps to reduce and remove additional waste and helps to maintain that acid-base balances. This occurs primarily in the distal convoluted tubule and collecting ducts, and usually what you'll see secreted is hydrogen ions, which help to regulate the pH level, potassium, which is regulated by that aldosterone, and ammonia. So if you remember, we talked about that with the buildup of our liver enzymes. So ammonia, creatinine, and drugs and toxins are also helped to be secreted in those tubules. If our tubules and our kidneys fail to secrete a buildup of acid, and this leads to that metabolic acidosis that we talked about in our first lecture. We can have a concentration of urine. This occurs in the loop of Henle in that collecting duct. Typically in the descending limb, that's permeable to water. So that's where that water will leave the filtrate and cause a higher concentration of urine. In the ascending limb, this is typically permeable to sodium and chloride. So salt leaves the filtrate typically. This creates a concentration gradient that can allow those kidneys to conserve water when needed. ADH, our antidiuretic hormone, and aldosterone also act in this area. So that ADH, which is secreted from that posterior pituitary that we talked about in week 1, reabsorbs the water. The aldosterone, which is from that adrenal cortex that we talked about, helps to reabsorb sodium and excrete the potassium. So during that time, the final product after filtration, reabsorption, and secretion would be our urine output. So that remaining fluid is about 1% of filtrate or toxins, and this is what becomes urine. That urine flows out and goes into the collecting ducts, goes then into the renal pelvis, into the ureter, the bladder, and the urethra, and is excreted. Our normal output should be about 1 to 2 liters per day. This can be either diminished due to dehydration or medications, or it can be increased due to excessive water consumption or other medications like a diuretic. Okay, so here we're going to go a little more in depth on the functions of the kidneys. So kidneys are the vital organs that maintain the homeostatic balance related to chemicals and fluids. They do have that endocrine and regulatory roles, which help to maintain blood pressure through ADH and the RAS system, and then red blood cell production, calcium balance, and acid-base stability. So we'll first talk about the function of the excretion of metabolic waste. So the kidneys eliminate those waste products that are produced from the metabolism throughout the body. So your main waste products are urea. So this comes from the breakdown and metabolism of protein throughout the body. Creatinine, which is from the breakdown and metabolism of muscle. Uric acid, which is a breakdown from nucleic acid, and then ammonia levels and drug metabolites. So these are from medications and typically a waste product from our liver. These are usually filtered through the glomeruli and excreted into the urine. So what we see is our BUN and our creatinine levels increase, and this typically indicates impaired kidney excretion. So we want normal BUN and creatinine levels, which show that we're increasing or wasting those products effectively. When those levels increase, this would be your first indicators for impaired kidney function, and so we'll talk about that later in our lecture. Then when we look at regulation of fluid and electrolyte balance, our kidneys help to regulate our fluid volume and our electrolyte concentration by controlling how much water and solute are excreted by the body, so get gotten rid of or exited, or retained, held onto. So we have our sodium levels. Now, sodium and water are usually closely linked, so sodium follows water. Their reabsorption is influenced by aldosterone and our ADH, or antidiuretic hormone. So if we have a high level of antidiuretic hormone, our kidneys will reabsorb water and lead to concentrated urine. When we have overhydration, we will have a decrease of ADH, and our kidneys will excrete more water and lead to a dilute urine. We also have our potassium that's excreted in our urine, so we want to watch out for that potassium loss in our patients with excessive urination. This is due to that excretion in the distal tubules. We then have calcium and phosphate excretion or regulation. This balance is regulated by the kidneys through the activation of vitamin D and parathyroid hormone. For our kidney function of regulation of our acid-base balance, our kidneys help to maintain a normal pH level, which is 7.35 to 7.45, by excreting those hydrogen ions. And it helps to buffer our pH level when it gets too acidic by reabsorbing or generating that bicarbonate. So if our kidneys fail, hydrogen ions start to accumulate, which leads to that metabolic acidosis. So for example, our patients with kidney failure will oftentimes have metabolic acidosis due to that increase of hydrogen ions, and our body helps to compensate by increasing their respirations, which we see in Kussmaul respirations, we talked about in respiratory, to help try to blow off the increased CO2 levels. Then we have our regulation of our blood pressure, and we'll talk about that in the next slide with our RAS system. This is our renin, angiotensin, aldosterone system. But our kidneys help to play a vital role in controlling our blood pressure through the use of that system. This is primarily looking at how angiotensin and aldosterone will help to increase the blood pressure and restore renal perfusion. So we'll talk about that on the next slide. Our kidneys also help with erythropoietin production, or red blood cell production, through the secretion of EPO, or erythropoietin. This is usually in response to low levels of oxygen in the blood, that hypoxia, and so the bone marrow is stimulated to produce EPO, or EPO stimulates the bone marrow to produce red blood cells. If the kidneys fail, we have a decrease in that EPO, which can lead to anemia, which you would see in your patient, that fatigue, pallor, decreased oxygen capabilities, and so you would want to treat that patient. We did talk about the red blood cell loss and anemia in our hematology lecture. So remember, our synthetic epogen would be given for those patients to help with production of red blood cells in the bone marrow. Our kidneys also help with activation of vitamin D. So our kidneys convert inactive vitamin D into calcitrol, which is the active form of vitamin D, and calcitrol helps to absorb calcium and phosphate in the intestines, which help to maintain that bone health. If we have a kidney disease, we will have a decrease in vitamin D activation, which can lead to hypocalcemia and hyperparathyroidism. Both of these, if you remember way back, lead to bone disease and can lead to renal osteodystrophy. We also have kidney functions looking at water conservation and osmoregulation. So the kidneys typically will respond to changes in the plasma osmolality, or that concentration of solutes in the blood, and will help to release ADH, that antidiuretic hormone. This goes into the collecting ducts and helps to increase water absorption, so it holds on to water and helps with conserving that fluid. This helps to maintain that fluid balance and blood pressure in our patients. So we've seen in the past with our endocrine lecture, we talked about diabetes insipidus with that lack of antidiuretic hormone, which leads to an excess in dilute urine and dehydration. So diabetes insipidus, dry inside, an excess of urine due to the lack of antidiuretic hormone. For our kidneys, they also help a little bit to detoxify and get rid of drug elimination. So our kidneys filter and excrete metabolized drugs and toxins. This is typically done in the glomerulus through glomerular filtration. So drugs like antibiotics, like aminoglycosides, NSAIDs, and contrast dye can be very nephrotoxic. So you always want to assess your renal function through labs like BUN, creatinine, and GFR before giving any medications that can be toxic to the kidneys to make sure that the patient can filter it out. And we'll talk a little bit more about that when we're talking about contrast dye and nephrotoxic medications. We also have glucogenesis. This occurs during fasting, so prolonged fasting or starvation. Those kidneys can actually assist the liver in maintaining blood glucose levels by helping to synthesize glucose from amino acids. But overall, we really need to just focus on kind of the regulation of blood pressure with the kidneys, acid-base imbalance, regulation of fluid and electrolyte imbalance, and how they get rid of waste throughout elimination. So we're going to now discuss the RAS system. The renin-angiotensin-aldosterone system is a hormonal feedback system that helps to maintain blood pressure and utilizes a negative feedback loop. It also helps to maintain sodium-water balance and blood volume. So the RAS system is activated when the kidneys detect a low blood flow or low blood pressure, low sodium level, or low volume level. Typically, this is seen in massive hemorrhage, shock, or in severe dehydration. So first, our decreased renal perfusion causes the kidneys to stimulate renin release. These renin cells are released into the bloodstream and start moving into the liver. So the renin moves into the liver and is then stimulated into creating angiotensin 1. Renin is converted to angiotensin 1. This then circulates through to the lungs, where angiotensin converting enzyme, or ACE, converts that angiotensin 1 into angiotensin 2. So angiotensin 2 is the active molecule that's helped or responsible for helping to raise that blood pressure. So ACE converts angiotensin 1 into angiotensin 2 in the lungs. Angiotensin 2 then has 3 major effects that help to increase blood pressure and restore kidney perfusion. So first, it vasoconstricts. This typically occurs in the arterioles. This constriction leads to increased systemic vascular resistance, which can help to increase the blood pressure. In the adrenal cortex, aldosterone is then released, and this helps to increase our sodium level and water reabsorption, and this occurs in the distal nephron. So that helps to increase the blood pressure through increased volume of fluid. Then in our posterior pituitary, our ADH, or antidiuretic hormone, also known as vasopressin, is released, and this also helps to promote water reabsorption in those collecting ducts. So this further increases water volume and blood pressure. So all three of these actions by angiotensin II helps to increase that blood pressure, renal perfusion, and cardiac output. So now that the kidneys have that perfusion there, it signals the kidneys to stop releasing renin because our blood pressure and our renal perfusion has improved. So that's through that negative feedback loop. So in summary, I'm going to repeat it again. For our RAS system, we have a decrease in blood pressure or a lack of flow to our kidneys, which stimulates that renin release to occur. Renin will then convert to angiotensin 1 in the liver area. That angiotensin 1 travels through the blood to the lungs and is converted to angiotensin 2. Angiotensin 2 helps to vasoconstrict, increase our aldosterone secretion, and release antidiuretic hormone. This leads to an increase in sodium. Water follows sodium, so water is then retained, increasing our blood volume, which increases our blood pressure and helps to restore that perfusion to the kidneys. Some of our medications that we need to be aware of with our RAS system is ACE inhibitors. So remember, ACE helps to convert that angiotensin II. So if we take ACE inhibitors, medications like lisinopril or enalapril, those end in pril, this can actually lead to decrease in our blood pressure due to vasodilation. So it actually blocks that ACE from occurring. ARBs, or angiotensin II receptor blockers, actually block angiotensin II from having that receptor working. So these are medications like losartan and valsartan lead to a decrease in aldosterone and a decrease in vasoconstriction. Then we have aldosterone antagonist medications like spironolactone. These actually will block aldosterone's action on those kidneys and can lead to a decrease in sodium and water retention and can lead to an increase in potassium. So just remember that medications can actually act on this RAS and can decrease our blood pressure, can increase urine production, and lead to a decrease in that water and sodium retention. For our patients, we want to make sure that we get a really good subjective assessment health history when the patient comes in, especially if they're complaining of any changes in their urinary habits. So we want to ask them what urinary changes they've had, what characteristics their urine has, things like the color, consistency, if it's cloudy or clear, if there's any odor or things like that. We want to get any characteristics of their pain. So are they having any flank pain in their back? Do they have any abdominal pain down in their bladder area? Changes in voiding habits. So do they have any increase in urinary frequency or decrease in urinary habits like urinary retention? We want to get a past medical history. So ask them if they have any history of any kidney failure, urinary retention, BPH, diabetes, anything that could affect the urinary system. Making sure that we get a good medication history. We need to know if they're on any medications like diuretics that could increase urinary output, any over-the-counter medications or herbal supplements that may change their urinary output. We also want to look at lifestyle symptoms like fluid and electrolyte intake, sexual activity, anything that could cause a barrier or an obstruction of the urethral opening. We want to make sure to get any family history or past medical history, things like chronic kidney disease or hereditary renal disorders as well. So getting a really good subjective assessment, asking the patients all these questions to get that background to see if there's any problems with their urinary system. For our objective assessments, we're going to look at a general appearance. So we're going to look at the patient, see if they have any fluid buildup, like edema, any weight changes. Remember, water and fluid really weighs heavily, so we want to weigh them, gather that information. We want to look at things like their vital signs, looking at their heart rate. Are they tachycardic, which may indicate a fluid dehydration, or are they having normal heart rates? Blood pressure, are they hypotensive, which can typically show dehydration, or are they hypertensive, which may show a fluid overload? We also want to do things like a good abdominal assessment, palpating for bladder distension, making sure that they're urinating appropriately, making sure we look at urine color and consistency, looking for any odor, any color changes, blood clots, and look at the amount of urine that they're having. Then we'll go ahead and gather our laboratory results. So our BUN, our creatinine levels, and our GFR levels should be within normal limits. We'll then look at things like our electrolyte lab levels, especially our potassium and sodium, which could indicate a disorder of our urinary system, and then take a urinary sample. We can do a UA or a clean catch urine, depending on what the provider or what we may be looking for with our diagnostic problems. We can also do diagnostic studies, things like a cystoscopy, which we'll talk about in a later slide. We can also do CT, MRI scans, looking at the configuration and the structures of the urinary tract. And then we can do a bladder scanner. This tells us how much urine is in the bladder with patients with retention. For our laboratory results, or our abnormal versus normal characteristics of our urine, normal urine should typically be pale yellow to clear and should have a specific gravity. This is the amount of chemical particles in the urine. So our normal gravity level is 1.01 to 1.02. Typically, we'll have a normal pH level of 4.5 to 8. If it's less than 6, that typically is more of an acidic level of a pH in our urine. Greater than 8 would be more alkalinic. With our coloring, our normal color, again, should be pale yellow to clear. If it is a dark amber color, tea-colored, that can usually indicate dehydration or jaundice. We may see red or pink urine, which can be due to blood, hematuria buildup. This can be from stones or different problems like glomerulonephritis, which we'll talk about later. We can see different colors of urine actually, like orange or blue, which would indicate medication use. So if you do not see normal colored urine, yellow or clear, make sure to assess the patient, ask them if they take any medications, have they been drinking appropriately, look at lab levels, which could indicate a problem. Then we want to look at the clarity of the urine. So urine should be clear. You should be able to see through it. If there's any cloudy or haziness to the urine, this could indicate a bacterial presence and a presence of those WBCs. If it's foamy, it could be due to a buildup of protein in the urine as well. So we want to make sure it's nice and clear. When we are looking at the odor of urine, there should not really be any type of odor, really. It shouldn't really stink, smelly, or be strong. If it has a strong ammonia smell, so that kind of smells like that really strong odor like cat urine, that could indicate an infection. If it's sweet or fruity flavored, again, that could be a sign of diabetes and maybe a DKA buildup there that we talked about in endocrine. A fishy odor could be from an infection of the urethral opening. Excuse me. Good grief. Okay, sorry about that. And could be from a UTI or urinary tract infection. Now, we want to also look at the amount of urine. Our normal urine should be more than 30 mLs per hour. which usually will be about 1 to 2 liters per day. When we have a patient who has lower amounts of urine, less than 400 mLs per day, that is typically documented as oliguria. If they have less than 100 mLs per day, we will call them anuric. This is typically minuscule to no urine output in that time frame. Polyuria is an excess of urine output. So this is typically more than 2 liters per day. So that's what you would document with your patient. So be familiar of these abnormal findings as well as normal findings of the urine so that when you're assessing your patients, you can recognize those cues and you can document those effectively. So one frequent diagnostic test that you'll see quite often in most patients is a UA or urinalysis. This can be a clean catch urinalysis where we will clean the patient's urethral opening, have them void a little bit, stop the flow of urine, and then have them urinate into a sterile cup. Just depends on what test they're looking for. Otherwise, we will do just a clean urine sample. It doesn't necessarily need to be sterile or anything like that. And we're looking for different changes in the urine. Usually our first morning sample is preferred. This gives a really good indication of concentration of that urine and will give most of the information. So usually send that first sample of the morning. If not, you can send a normal urine sample. And this is looking at the color of the urine, which we talked about, that clarity, looking for any WBC buildup or frothiness or uh, cloudiness of the urine. They're able to check that pH level and look at their specific gravity and concentration of those solutes. We can also take protein samples looking at levels of protein. We can do a glucose check, do a ketone dip, and look at WBCs and red blood cells as well. So this looks at things like proteinuria, DKA. It can look at signs of infection, looking at WBCs and things like that for a urinary tract infection to rule those out. Oftentimes, what we want to do is we do want to collect midstream that sample. This is to help with making sure that we actually get the amount of bacteria or white blood cells that's in the urine, not just sitting at that urethral opening. So the way you do that is you'll have the patient start to urinate and then stop the flow of urine by bearing down, and then they can go ahead and urinate again into the cup. Making sure that we label those correctly at bedside and sending those samples down immediately so that there's no abnormal bacterial growth from them sitting at the nursing station waiting to be sent to lab. Some medications or some lab levels, not medications, some lab tests and studies can be collected over the course of 24 hours. So we'll talk about that when we talk about our GFR and glomerular nephritis, but we often take a GFR with a 24-hour urine collect where we're collecting their urine for the entire 24-hour period. This urine needs to be kept in a giant jug, and usually it's kept on ice so that no abnormal bacteria will grow in that urine. So just remember, you may see that where they're collecting a 24-hour urine collection and it's kept on ice, so kept cold, and over 24-hour period. Okay, so we're going to talk a little bit more in depth on our lab levels or our diagnostic studies for our urinary system. So I mentioned up top BUN. BUN is our blood nitrogen urea. This helps to reflect those urea levels, which is a waste product of the kidneys and is usually elevated in dehydration. So this is from protein metabolism. Then we have our creatinine level. This is our best indicator of our renal function. In our kidney impairment or nephrotoxicity, this is increased. When we look at our BUN creatinine ratio, this evaluates our hydration status versus renal injury. So our BUN creatinine ratio will be high in dehydration and typically lower in intrarenal damage. Our GFR or glomerular filtration rate, This helps to estimate that kidney filtration rate and is usually used to stage our kidney disease. So we're going to talk about our GFR level in chronic kidney disease especially. But our normal GFR should be greater than 90 mLs per minute. So that's something to remember. We also want to kind of remember our BUN and creatinine levels. The BUN, creatinine, and GFR are very common. We test these in most every patient that you'll see. So make sure you kind of are aware of what some normal levels are. Okay, so here is that slide talking about that creatinine clearance test or our 24-hour urine collection. This is where we look at our GFR clearance, how efficient our glomerular filtration is, and is usually a good calculation of how those kidneys are actually functioning. So again, you might have a patient who's on a 24-hour urine collection test to look at the amount of creatinine that we're clearing, and it will be kept on ice in big giant jugs and then gets sent down to look at that function of the kidney. Okay, so we have a couple diagnostic studies that are specific to our urinary system. One of the main ones that you'll probably see out in clinicals is a KUB. This stands for kidney, ureter, bladder X-ray, and this helps to identify any kidney stones, any tumors, or structural abnormalities that might be in the kidneys or the ureters or the bladder. There is a renal ultrasound. This is an ultrasound that will help to detect any obstructions or masses or anything that could be prohibiting the patient from having normal urinary function. If we need a little more detailed look of the kidneys and bladder, we may do a CT or an MRI. Oftentimes, we might use contrast dye and do an intravenous pyelogram. This is looking at the flow of the urinary tract and uses that contrast dye to help light up those structures. For your patient with any type of contrast, we want to make sure that we assess that kidney functioning, making sure that we have okay flow through the kidneys, assess for any allergies to iodine because contrast is made with iodine, and making sure that they have adequate hydration. Usually after a patient is given any type of IV contrast, we also will increase hydration either through oral hydration, water intake, or IV fluids just to help flush that contrast out through the kidneys. But we want to make sure that we test those lab levels prior to make sure there's no dysfunction of the kidneys that could prohibit the contrast from being excreted or the contrast damaging the kidney function completely. Okay, so one of the frequent diagnostic tools that we can use for our urinary system is called a cystoscopy. So this is a little flexible camera. It's very similar to an endoscopy procedure that we talked about with GI, but this goes in through the urethral opening up into the bladder and can help with direct visualization of the bladder and, those structural areas of the kidneys, not the kidneys, of the urinary system. It's used to help detect any stones or tumors of the bladder and urethral opening and can help look at any structural issues related to the flow of urine from the bladder. Remember, for our pre-procedural checklist, we want to make sure that they get informed consent since this is, inserting a tube into the sterile area of the bladder. It can increase risk for infection. It can increase risk for bladder perforation, so that flexible tube can actually, poke through the bladder and can lead to bleeding. We also want to make sure if the patient has any anesthesia that we educate on risks of that and making sure that they're nothing to eat or drink after midnight, so NPO prior to that procedure. Also want to hold any blood thinners or things like that that could increase the risk for bleeding. After procedure, we want to make sure that we monitor for any hematuria or bleeding through the urine, monitor for any urinary retention and any problems, signs and symptoms of any burning or infection that could occur there. Okay, so for our elderly population, we do sometimes have some age-related changes to our kidney function and our urinary output. But for the most part, what we see is due to a decrease in renal blood flow. So this leads to a reduced GFR. Most of our patients in increased age can have changes in bladder capacity, which can lead to incontinence or urinary frequency or urgency. So we see that sometimes. Now, it's not all the time that elderly patients lose control of their bladder, but you do see it more frequently. We do see more of a prostate enlargement or BPH issues, especially in our men, and this can lead to an increase in urinary retention, increased urinary frequency, and problems with their urination. Oftentimes, elderly patients have a diminished ability to concentrate urine, which can lead to nocturia or increased urinary changes at nighttime. So they have to get up frequently at night to go to the bathroom. In our female patients, we have changes with our postmenopausal changes. This can lead to urinary dryness, decreased urine output, which can lead to an increase in infection. So just be aware of these. It's not every older patient, but it is more common in patients with advanced age to see these problems with the renal changes. Okay, so for our urinary system, just remember to monitor our patient's output. We should have greater than 30 mLs per hour. If you have less than 30 mLs per hour over the first 2 hours, you'll want to notify the doctor. Okay, so really notify that doctor if their urinary output decreases. We want to make sure there's no obstruction or the kidneys have not stopped functioning. When we're looking at our fluid balance, we want to make sure that we weigh them daily and look for signs and symptoms of edema. So that's how we would check to see if they're retaining fluid. We want to evaluate the use of nephrotoxic medications, things like Lasix, those diuretics, any medications that could either increase urine output or decrease urine output. We want to increase and encourage hydration, especially for patients that might be dehydrated or not having enough urine output, really making sure that they're taking PO hydration, if not IV hydration. But just make sure that this is not contraindicated in patients. So if they have an increase in fluid retention, we would want to avoid overhydrating. Then we want to make sure that we educate on prevention of disorders of our urinary tract, things like urinary tract infections. We want to avoid dehydration, make sure they take a balanced diet, and just make sure that we educate on a healthy urinary system. Here I have some NCLEX questions for you on this chapter.